So I'm going to talk to you guys about the management of cervical and lumbar radiculopathy. I'll focus on cervical stuff and then and also show you some work that we've done in our practice to look at outcomes and timing of surgery, and then I'll do the same thing with lumbar radiculopathy and look at some stuff that we've done as well. So starting with cervical radiculopathy, there are multiple causes underlying radicular symptoms. You can break them into all kinds of different categories, but the broadest ones are compressive versus non-compressive. As Dr. Turner spoke about, infectious, and there's other root avulsion and those sort of things. The most common reasons we see cervical radiculopathy are for spondylosis and disc herniation, which are mechanical compression. If you look at individual patients, they have a range of signs and symptoms depending on where the herniation is. You might want to study this slide if you want to get your question right. So, one of your questions. If you have a C4-5 disc herniation and you're pinching the C5 nerve root, then you have certain numbness and weakness in certain areas, abduction of the arm. Similarly, C6, you have a C5-6 herniation, pinch the C6 nerve root, biceps weakness, and C7 tends to, C6-7 disc herniation would affect C7, which triceps weakness, and so on and so forth. Everybody get that? As far as the management of these of cervical radiculopathy, it can be widely variable. If you look at the literature, some papers quote up to 90% of patients will improve without surgery. That's probably a little bit high. On the other hand, I've had patients come in with a disc herniation and as a second opinion, and they say, well, it took me 4 weeks to get in to see you, and I saw this other surgeon 4 weeks ago, or I saw this other surgeon, and he looked at my MRI and said, well, you have a big disc herniation, so you need surgery. And I said, well, what have your symptoms been doing? Oh, well, when it first happened, when I was picking up the rocks in my garden or whatever, I had horrible, excruciating pain, couldn't move. And I said, well, now you don't look that bad now. Oh, well, it's almost gone. And I said, okay, so you're here for surgery, because you sort of make a surgical appointment. I said, well, why do you want to have surgery? Well, the other surgeon told me I needed surgery. There's no, I said, what about, did they talk to you about physical therapy, injections, or anything like that? Oh, he said those don't work. Oh, okay. So obviously there's a wide range of opinion. Some people think they don't. Other treatments outside of surgery don't work at all. I'm sort of in between here. I usually quote about 65% of patients will get better and have complete symptom resolution without surgical intervention, and about 35% will end up with surgery. Now that's obviously depends on age and disc size and all kinds of different things. So conservative management, another wide range of things. Typically we start with anti-inflammatories. You can give oral prednisone, physical therapy, steroid shots. Within the steroid shot category, there's multiple indications. Severe disabling pain is typically what I use. I send a lot of patients for injections because I think they work. Sometimes it's temporary. Sometimes they need more than one injection. Sometimes they don't work at all. But most of the time they work to at least a certain extent. There are multiple kinds of injections depending on where the disc herniation is or what the symptoms are. You can do interlaminar injections. You can do transforaminal injections that select for that particular nerve root. Wide range. And then depending on if symptoms are refractory and progressive, then you can go from conservative, and it's reasonable to go from conservative management to surgery. So what are the indications for surgery? Unremitting pain. So what I tell patients, most or a lot of patients come in and talk to me and they say, well, and the most frequent question I get is, do I need surgery? Or should I have surgery? And almost invariably, with the exception of a patient who's got a big brain tumor that's going to die if they don't have surgery, I always tell them, well, it's really your decision, it's not mine. And, pain is a relative indication for surgery. When you're dealing with spine things, unless you have spinal cord compression, something like that. It's really a quality of life issue. So how bad is your pain? Is it worth going through surgery? Then do it. If it's not worth going through surgery, then don't do it. That's basically it. I can tell you what surgery I would do, and I can tell you what the likelihood of improvement is, usually, but I can't tell you whether you need surgery or whether you should have surgery in these degenerative conditions, which is mostly what we see. So let's say you are going to have surgery. What surgery should you have? So for cervical radiculopathy, again, there's a wide range. By far the most definitive thing is an anterior cervical discectomy infusion. You remove the whole disc, you jack the space open, you put a graft in there, you elevate the height, you increase the foraminal size, you restore the normal lordosis, and you lock it into place with the plate. Almost everybody gets better, invariably. There are disadvantages. Almost everybody has some degree of swallowing difficulty after surgery. There's other risks, recurrent laryngeal nerve injury, which is exceedingly rare, fortunately, but does occur. Bleeding, infection, nerve injury, spinal leak, those are all very, very rare, but they can occur. So what about just a plain old anterior cervical discectomy without a fusion? Well, that's a possibility too, and there are advantages to that. It's less costly, you don't have a fusion, but when you come in through anteriorly, you disrupt a lot of tissue, and there's an increased chance of postoperative kyphosis and residual symptoms, loss of disc height, further loss of disc height, collapse of the foramen. So it's definitely not as definitive, and it has some other drawbacks. Everything has pluses and minuses. What about posterior laminal foraminotomy? Well, that is the greatest surgery if it works, because there's no fusion, there's no anterior cervical approach. You just go in the back, and I can do it with a little tiny, barely more than a centimeter incision, do a little foraminotomy like it shows right here, maybe pull this lateral disc out. The problem is it doesn't always work. There's probably, what I quote, first of all, if you have a central disc herniation or spinal cord compression, forget it. This is out of the question. It's way too dangerous. You can't. It's not like the lumbar spine. You can't pull the spinal cord over to the side to get it. They'll wake up a quad. Not much point in doing surgery if that happens. So you have a much more limited select group of patients that it's eligible on. Even those patients, sometimes you just can't. You're coming in from the back and the disc herniation's in the front, and you have high-priced real estate in between you and the disc herniation. So a lot of times you just can't get there. So I tell patients, if you have an anterior cervical discectomy infusion, almost invariably you're going to get better. If you have posterior cervical foraminotomy, you don't get a fusion, but there's probably a 20% chance, you can't get the disc out, or you have residual symptoms or something. Peyton Manning had a foraminotomy, didn't work, and he had a fusion, had a non-union, then had another fusion. So anyway, that's a perfect example of what can happen. Like I said, there's multiple contraindications to that procedure. What about artificial disc replacement? Basically, the indications for artificial disc replacement are almost identical to anterior cervical discectomy fusion, with the exception if you have too much kyphosis or if you have too much of a collapsed disc space. You can't just go in there and jack the disc space open as much as you want to restore lordosis, because the problem is you're changing the angles. With an artificial disc replacement, you're putting a new joint in, and you're basically maintaining motion. So if you change the angles, then you're going to change the way those joints move in the back, and it also, it's not really strong enough to jack disc space open and give the patient more lordosis, because then you could dislocate that artificial disc. So again, there's more limited patients that's available for them. A little more challenging. Complications. You can have spinal cord injury, very rare. Nerve root injury. The complications are fairly rare, with the exception of dysphagia, which I don't really consider a complication. It's a side effect of this surgery, because you go into the front. The esophagus sits right in front of the spine. You have to move it over. You can't do these surgeries, and pretty much everybody has at least a little bit of swallowing difficulty, which usually, fortunately, goes away, but not always. So what about timing of surgery? When should conservative surgery be ceased and conservative treatment be, stop and actual surgery be considered? Well, there's really no, until this study actually, there was absolutely no good data in the literature. It's pretty much all retrospective. So we actually looked at the duration of symptoms and clinical outcomes in patients undergoing anterior cervical discectomy and fusion for degenerative disc disease and radiculopathy. The study design was a prospective clinical study. It was a post-hoc analysis of another prospective randomized trial we did on ACDF patients that we were looking at different types of bone grafts. The primary purpose of this study was to analyze if duration of symptoms had any effect on clinical outcomes and resolution of radicular symptoms in patients undergoing ACDF for radiculopathy. Patients were divided into two groups, whether they had surgery within 6 months of their symptoms starting or after 6 months. Outcome measures were visual analog scale, SF-36, mental and physical component scores, neck disability index, patient satisfaction. This just shows that the demographics were all pretty similar, same exact number of patients in each group. There was nothing statistically significant between the two. Similarly, the preoperative clinical data was about the same for the less than and greater than 6 months patients. So for the patients who had symptoms for less than 6 months, you can see here that after surgery, so this is preoperative data and postoperative data. Almost all of them got better, statistically significant. Pretty much everybody got better if they had symptoms for less than 6 months. After 6 months, patients got better, statistically significant from a neck disability index standpoint and from a VAS, but it was not statistically significant from a VAS arm SF-36. So right there you can see there's a difference. We just need to look more closely at what exactly was the difference. So we looked at the postoperative clinical data, specifically comparing the less than 6 months versus greater than 6 months. There was a trend in every category. The patients that had symptoms for less than 6 months did better, but the only one that was statistically significant was visual analog scale arm pain. So, when you say it's statistically significant, that means the p-value was less than 0.05, which means, translates into, there was a less than 1 in 20 chance that this outcome occurred by chance alone. Okay, so these results, even though there's no really prospective data in the literature before this study, the data is consistent with most retrospective analyses, which show that basically patients who had symptoms less than, on the lower side of the time frame did better. It's controversial in all these retrospective studies, whether it's 4 months, 12 months, 3 months. That jury's still out. And our 6 months was fairly arbitrary because half of our patients had it before 6 months and half of our patients had it after 6 months, so that's where we decided to look. So that, if you really wanted to find that, as far as how long should it be, we need more and better research for that. So basically what I can say from that is duration of symptoms is not necessarily a negative prognostic factor, although it can be. And there are limitations to this, to the other retrospective results as well as ours. Neck pain and upper extremity radiculopathy obviously can be treated successfully without surgery, but in those cases that do need surgery, patients with shorter duration of symptoms tend to have better improvement in radiculopathy symptoms if they're treated within a timely fashion. So, what about lumbar radiculopathy? Similarly, you can have radicular pain, back pain, muscle weakness, lots of different symptoms, lots of different potential pain generators. It can be discogenic pain, it can be facetogenic pain, it can be radicular pain, all kinds of things. Pathophysiology ranges from classic pain radiating down the leg from nerve compression versus other, degenerative arthritic changes in the joints. You can categorize it into multiple different levels of severity, and whether it's pure sensory, mild motor, marked motor deficit, similar to cervical radiculopathy. There's multiple different syndromes depending on what level. You have the disc herniation. If you have an L3-4 disc herniation, you typically have at L4 root compression, although if the disc is far lateral, then you can get L3. But there's associated losses of reflex and sensation and motor that we look at in trying to determine where the patient's symptoms are coming from and if we need to operate or not operate. This is an example, two examples of causes of lumbar radiculopathy. And this is an axial view, lumbar MR. You can see a huge disc herniation causing severe root impingement. Typically, we treat that with anti-inflammatories, physical therapy, steroid shot. If that all failed, we do a little micro decompression, discectomy. In this case, it's a different etiology. So this is a sagittal view of lumbar spine. You can see here's the neural foramen here. I don't know if you guys can see that. So here's the neural foramen laterally, and then you come down to this one, and it's just squashed. And that has more to do with disc-based collapse and alignment. It's not a focal disc herniation. So that would typically require a fusion to elevate that foramen height, foraminal height and alignment back to normal. Because if you go in and do a discectomy, you're not going to do much. If you take the whole joint out, yeah, well, it'll improve, but then you have an unstable spine. So when do you refer to as a specialist? Progressive weakness or numbness, persistent weakness or numbness, intractable pain. Again, that's a relative indication. Persistent symptoms for greater than 6 weeks. What are the surgical indications? Same, basically, can be similar indications for why you refer. Everything's controversial when you talk about surgical indications. You ask 10 different surgeons that question, you'll get 10 different answers. Similarly, primary care docs and everybody else. What are absolute indications? Well, I think everybody could probably agree that if you have Cotter-Aquinas syndrome, you're losing bowel and bladder function, or you have a severe progressive motor deficit, it's getting worse and worse, then that's probably a surgical indication. Other relative indications, like I said, pain is a relative indication. This is a good one. Whoops. Large extruded disc fragments. I can't tell you how many times I've had patients come in with a big giant disc herniation and they'll say, well, I need surgery, and then it's similar to the patient who came in, took them a month to get in. Okay, well, you're sending, examine, they're neurologically intact, they're not in that much pain, but they have a huge disc herniation. Well, I mean, it's the same thing, it's relative. I don't treat patients. I don't treat x-rays, I treat patients. So, the MRI and the x-rays are helpful in deciding what treatment, you need, but most of the time an MRI is not going to tell you a patient needs surgery. It doesn't matter how big the disc herniation is, although some surgeons, probably the same one who doesn't believe in any medications, injections, physical therapy, they're going to think that the patient needs surgery, clearly. So what about surgery? If you do have surgery, similar to cervical, what do you do? There's open lumbar laminectomy and discectomy, fairly good results in the literature. You just have a big giant incision, and it takes a lot of time to recover. Micro discectomy, same efficacy as far as resolving the disc herniation and the radicular symptoms, but you improve a lot quicker, and it's, most of the time these days it's outpatient. So what about recurrent disc herniations? When should patients be fused? Well, there was a paper that came out in Spine, I think it was about a year ago, that looked at, should we wait until, so if a patient re-herniates, should we do another discectomy, or should we do a fusion then, or should we wait till they herniate a third time to say it's fusion? Well, they looked at the data, and the patients that had surgery after the second herniation did better than the patients after the third herniation. So their conclusion was, after they re-herniate, just fuse them. Well, that's great. If it's a 60-year-old and they have horrible degenerative disc disease and disc-based collapse and foraminal narrowing and all that stuff, and you look at that, and this is where an MRI is very helpful. And you think, well, if I do discectomy, it's probably still going to be in pain anyway. Whereas if you have a 35-year-old who herniates for a second time because he's trying to do a double Ironman or something, and he's got an otherwise normal disc height and foramen and all that, I mean, you have to be out of your mind to do a fusion on that guy. So, you got to take everything with a grain of salt. Every patient is different. We're like snowflakes, right? So, okay, so what are we talking about? Duration of symptoms in fusion so same thing. We looked at, there's not great data about this stuff for lumbar disc herniations in the literature either. So we thought we'd look at that as well. So background, obviously surgical rates, success rates of surgical intervention vary depending on multiple factors, and duration of surgery is one of them. So radicular pain, in theory, is caused by mechanical compression and then an inflammatory response, and then if you leave it there, the compression long enough, then you get pathophysiologic changes, and eventually, if a patient comes into your office and they've had the same symptoms for 5 years, and you do surgery, that patient is probably not going to get better. Whereas if they come in and they've had the same pain for 5 weeks, there's a really good chance they're going to get better. So, but that's just by our experience, and that's not, proven data. So, but that's the theory. Okay, so the objective of this study, similarly, was to analyze whether duration of symptoms had any effect on clinical outcomes and resolution of the radicular pain undergoing fusions now, lumbar fusions. It was a prospective observational study. We looked at 84 patients. None of them had previous fusions. They all had 1 to 3 level T-lifts. That's transforaminal lumbar interbody fusion. And the clinical outcome measures were visual analog scale, SF36, oswestry disability index, and then satisfaction survey. We looked at them 3, 6, 12, 24 months. From a statistical analysis standpoint, in order to emphasize the change in clinical outcome, we used something that's a little different. It's called the minimally clinically important difference, which is complicated, but basically we looked at the change scores, which was the baseline score versus the post-operative score, and then we did multiple regression analysis to examine the relationship of the duration of surgery and this MCID ratio, which is becoming more prevalent in the literature. And we compared patients, again, based on the number of patients we had, less than 24 months versus greater than 24 months. And you might say, well, on the cervical, why did you use 6 months on the cervical radiculopathy one to look at duration of symptoms, and now you're looking at 24 months on lumbar? People tend to wait longer with lumbar issues. Everybody has back pain, and the stakes are a little bit lower, although you don't end up with foot drop. But when you have a dysfunction of your arm or your hands or myelopathy, central disc herniation in the cervical spine causing myelopathy, you have a much lower threshold for operating early because that's higher priced real estate, so to speak. So lumbar cases, they just tend to wait longer in general. So that's the number we looked at. Statistical analysis, again, we looked at the MCID scores for all those things. Looking at the demographics, there was no statistically significant difference. There was, even at 24 months, there was 28 patients in the less than 24 months and 41 patients in the greater than 24 months. So even using that higher number, there was a lot of patients that waited a long time. So looking at the results, the reoperations, complication rates, and stuff like that, there was no difference. This is what we're really interested in right here. Basically, the less than 24 months had a greater change, 3.3, versus the greater than 24 months, which had a lower change in their score, meaning they didn't improve as much, and that was statistically significant at 0.032. The ODI and SF36 were not. So, using the multiple regression analysis, controlling for age, sex, previous surgeries, T-lift levels, all that. Duration of surgery was the significant predictor for better outcome for radiculopathy symptom resolution, but not for back pain resolution, ODI, oswestry disability, or SF36. So what is the timing of surgery for microdiscectomy? Well, again, you look at the literature, one paper says less than 12 months, that's a Other papers say less than 12 months, 2 months, 12 months. Spondylolisthesis and stenosis are different. It's all over the board. So in a paper that looked at 380 injured Washington State workers' compensation patients, shorter time from injury predicted better functional outcome. In others, there's no correlation with duration of symptoms with decompressive surgeries for spinal stenosis. So there are limitations. Our study was not a prospective randomized trial, even though it was a prospective cohort. We did not take patients that came in with radiculopathy and say, okay, you're going to wait 24 months before you have surgery, and you're going to have it in less than 24 months. That's the ideal study, is you set preoperatively, before the treatment, you take all these patients and you say, you're going to wait X, Y, and Z, you're going to wait 6 months, you're going to wait 12 months, 24. That's how, that would be the best study. Unfortunately, patients aren't going to agree to that. Nobody's going to want to agree to be in the 5-year, wait 5 years for surgery study or arm. So, in conclusion, a shorter duration of symptoms was found to be a statistically significant predictor for better resolution of radicular symptoms in patients undergoing TLIF or radiculopathy due to degenerative disc disease and stenosis with spondylolisthesis. Okay, questions? Remember, I gave you some hints. A patient has pain and numbness in his middle finger and weak triceps. Which nerve root is affected? Oh, doesn't come up on my screen. There you go. So you guys were listening. Good. Most of you. I think Raj Paul, and we probably picked the other one. Okay. What are the most often encountered complications of cervical spine surgery? Okay. Nerve root injury, instrumentation or device failure, dysphagia, vertebral artery injury. I said this like 5 times. I actually said it wasn't really a complication, it was a side effect. Let's see who's listening, how many people. There you go. Okay, low back pain potential generators are facet joints, ligaments, intervertebral discs, paravertebral muscles, all of the above, except C, all of the above. Low back pain potential generators. I should have put wife, husband up there. Kids. Yeah. Okay. Good. What do you mean? No intervertebral discs. Now, how's that? Intervertebral discs are a potential pain generator. That's not right. Who put that in there? I don't know. Okay. A patient with low back pain should be referred to a specialist if experiences progressive weakness or numbness, symptoms persist more than 6 weeks, intractable pain, all of the above. Yep. Let's see if they give us a wrong answer again. Okay, good. Okay, one more. What are the absolute surgical indications for low back pain? Progressive numbness, cauda equina syndrome, instability, all of the above. Yeah, so this, this is an opinion, okay? Like I said, if you ask 10 different surgeons the same question, you're going to get 10 different answers. In my opinion, progressive numbness, is a pretty strong indicator for surgical intervention. Same thing with instability, but that's his absolute surgical indication. So It's tough. I mean, you could go either way. It's, you know, that's kind of a trick question a little bit. But cauda equina syndrome is definitely an absolute in case you lost a bowel bladder function. The other ones, I mean, instability is a good example. You know, people can have instability and not require surgery. They can come in and be grossly unstable, or let's say hypermobile on x-rays, and they don't hurt that bad. So that one. The progressive numbness is a little more iffy, but it's